that we learned, and then hopefully leave a little bit of time at the end for some, through the chat line, some questions. I'm hoping you know who the Change Foundation is, but if you don't, very quickly, we are a charitable foundation with a nice size endowment for our Canadian foundation. We were established by the Ontario Hospital Association in '95, so we're in our 21st year. We are a health policy think tank that does work to sort of encourage positive change in the healthcare system, but we have a variety of ways in which we do that. We do undertake our own research, both in-house and externally funded. We do a lot of policy analysis, but we also, which I think makes us a little bit different than some foundations, work very closely with frontline staff, with patients, and with family members to look at care delivery, to look at redesigning it, and to engage deeply with patients, caregivers, and staff on ways in which that can be done. These are the two summary reports that provide you with a lot more detail about the two exercises that I'm going to draw lessons from. These are just screenshots of the covers of the reports, and they are on our website if you want a lot more of the details. So I'm not going to go into any of that now.
Testing, 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 testing. We are back on. Apologize very much so for a little internet glitch that made us lose our audio, but we are back, and I'm putting the mic back to Kathy. Thanks for your patience, everyone.
Okay, so I have no idea where we lost you. So if we lost you earlier than this slide, I'm just going through a couple of projects at the Change Foundation that helped us create the lessons for engagement that we're going to talk about in a minute. So this is the first project, the PATH project, which was a partnership of 12 provider organizations in Northumberland Hills, originally focused on looking at transitions from hospital to home, involving patients and family caregivers in the design work from the get-go. When we got together with the patients and caregivers, they changed the focus quite dramatically. So it wasn't just about transitions anymore. They wanted to deal with the patient and family caregiver experience writ large in the community. So when you do engagement, you have to be very flexible, and therefore we spent 2 years of deep engagement with the community with an absolutely amazing group of people that looked at the work in the sort of processes of care, but also had a whole bunch of different spin-offs just because we had creativity in the room. And the work, I'm happy to say, has continued without foundation support, which I think is a testament to the stellar work that was done there. I'm not going to get into the details, as I said. There is a report on our website if you're interested in that one. The second project was a 3-year piece of work that we did as a foundation. We felt that if we were going to be promoting and pushing the idea of deep engagement and experience-based co-design, we as a foundation had to walk our own talk. And so we created a 32-member group of patients and family caregivers from all across the province to help us as a foundation stay true to our mission. We didn't have any specific project that we wanted them to tackle. We wanted them to be our sounding board, and as our board chair at the time said, a source of honesty about whether our work as a foundation was actually patient and caregiver centered. And they gave us great advice on all kinds of issues that came up over the 3-year period. The two that probably had the most impact for us was a piece of work we did with them around whether system navigators are a good idea. So, 3-4 years ago, and unfortunately still today, we're talking about lack of integration and how hard it is for people to move around the system. And so there was a notion that maybe we just throw a navigator in as another staff person on a team, and would that be helpful to patients and caregivers? And the answer was maybe. It wasn't an absolute yes, it wasn't an absolute no, but it was helpful for us because we went in assuming that they would agree. Secondly, we had a lot of conversation about paying for patient and caregiver participants in engagement exercises, and I'm going to come back to this in the presentation, but their advice again was sometimes. So based on those two exercises, I don't want to call them exercises, based on those two partnerships, we learned a lot, and I am going to go over our top 15 lessons. I'm sorry, we simply could not get it down to 10, and some of this is going to seem like common sense to you, and it is. But it is based on experience of an organization that had not done deep engagement before. We had done consultation, we had done dialogue, we had done focus groups, none of which I would categorize as deep engagement. So it is coming from a perspective of an organization that was starting. And really, my overall message to you is just be purposeful. Don't engage because you're made to do it. Engage because you need to and you want to. And it is hard. It takes a lot more work than certainly we thought. It's also extremely fun and rewarding and worth it as an organization to invest in this. So let me start with our lessons. The first thing to think about is offer people a range of formats. There's definitely, I think, a bit of a trend, particularly in the acute sector, to gravitate towards let's have a council. And that will be what we're going to do. And I'm not saying that's a bad idea, but it may not be something that works for everybody. And it certainly means you have a much smaller group of people that you're able to engage with. So think about councils, advisors, online work, different ways in which you might be able to expand your engagement format so that people have the ability to engage as it suits them. And obviously, not everybody is able to come in person. Not everybody is able to attend weekly or monthly, exercises. So think hard about what you're putting on offer before you start any kind of a recruitment exercise. Think about the time frame. Not everything has to be a 2 or 3 year commitment. There's nothing wrong with one-offs if that works for what you think you need. Some of them are shorter, some of them are longer. But do the assessment before you actually propose something so that you're clear on the time frame, and maybe, again, you have a variety of options. Asking somebody, as we did with the Panorama group, to sign up for 3 years of face-to-face meetings precluded a lot of people. So, we didn't think about that at the beginning, but we realized it as we got into it. Think about partnering, depending on where your organization sits geographically, depending on resources, depending on your mission and your role. Maybe you don't need to have something specific to yourself and something that spans a local community or is more regional or involves a number of like organizations who are in some kind of maybe a health link, for example. You don't have to do everything yourself, and if there's a logical partner or partners You often, first of all, it's more cost effective, but secondly, you really be able to share what comes out of your engagement exercises on a much broader level, which gives it, I think, more prominence, and also you can involve larger numbers of people. It's not going to work all the time. It's not going to work for everybody, but it's worth considering when you're doing your early assessments about how to proceed. Recruiting. Now, this is hard. You honestly can't just send out a notice. You really need to think about the mix of people that you need at the table. Obviously, you need people who are using or have used or will use your actual services. But you also want to think about a mix of people who are very new to engagement, but perhaps some who are more experienced, and maybe even a few who are viewed locally as champions of the role. So that mix is important. And diversity is incredibly, incredibly important. And I mean diversity in all forms, whether it's cultural, whether it's age, whether it's gender, whether it's income, whether it's education. We ended up, for example, with the Panorama group, we were very conscious that we had no clue how to do this. And we were able to hire an external partner to help us with a recruitment strategy. Now, not everybody's going to be able to do that or afford it. I know that. But thinking through representation. And when we got our initial list of folks, and so this was actually a polling company who had infrastructure to phone people, we realized we were still missing folks with disabilities, Aboriginal, and so we then went to a number of community groups and said, we need help. Can you find some people who might be interested in participating? Because we know even through our own, fairly tightly designed recruitment process, we still had gaps. And it's incredibly important if you're an out-facing engagement exercise that the community you want to engage with recognizes the community you have on your, your programs or your projects. So again, it's hard, but it is really worth doing, and multiple ways in which you can draw people in is probably the way you're going to have to go. I can't stress enough the importance of this. We screwed this up at the beginning. We didn't have a purpose and we didn't have objectives because we thought we were in experience-based co-design mode, which we were. And so once we got our teams together, things would evolve. Well, it doesn't quite work like that. So you need to be clear about what's on offer, what's the purpose, what are you as an organization hoping to achieve, and how does the engagement exercise play a very good role in that engagement. You need to be really clear with people about what success could look like, and that probably is something that needs to be co-designed. You need to understand success from the participants' perspectives, and you need to understand success for your organizational perspective. And you need to be very clear about expectations of level of involvement. If people don't understand, I have to do this, this, and this. Oh, I thought it was just a meeting, but now you need me to do stuff online in between the meetings. They're not happy campers. So be very, very specific about the level of involvement, and you may need to negotiate that as you get into, understanding and knowing your participants a little more. They're going to be a little bit more honest about whether or not they're getting irritated with you. So be open to that one. Again, this is hugely important. Be clear about your scope of influence. What are you able to do with the work that you're going to do with these individuals, and what can't you do? So I still remember, sitting in a Toronto hotel room a couple of years ago with our Panorama, first time we met with our Panorama group, our 35, 32 citizens, and trying to explain what the heck the Change Foundation was. And I actually had a slide that said, well, we don't make policy, we don't fund services, we don't provide care. And they're all looking at me, you could see the wheels turning. Why am I here? What am I doing with this organization? And so we had to be very clear about, we're a think tank, we try to influence, We do, good research that people try to use. We look at best practice, and we bug a lot of people to do the right thing. But we needed to be clear, and there were a few people, and you've got to respect this. That wasn't for them. They thought they were going to be able to get more services in their local community if they participated with us, and we had to say very clearly that is not going to be the case. So don't apologize, but be clear about what you can and cannot do. Oops, sorry, we're just... Okay. It's very important at the very beginning to set some ground rules. And this, you absolutely do not make the mistake of drafting them yourselves and giving them to the group. Do this together. Otherwise, you're already setting up a dynamic that is not in true partnership. And it's important to do this. You may think at the time you don't need it, or you may think at the time it's incredibly obvious, but do it anyway. And we used this little schematic that you can see here. We had blown up on quite a large chart that every time we met, we had on the wall. And it did allow both the facilitators and the participants to sometimes point to one of the rules to help a tricky conversation, particularly around surfacing, how would I put this? Getting people out of groupthink. So you really want to make sure that your process allows for differing views, and you really want to make sure that the airtime is shared and that you don't have particular individuals dominating. So setting those ground rules in advance with the people who are going to be participating is a really good practice, and using them and referring to them during your dialogues so that they are seen to be meaningful. You need to think about an exit strategy, and that may seem weird because, why would you do that at the beginning? But it's actually kind of important for a whole bunch of reasons, particularly when you have a longer term engagement. First of all, as people get into the dynamic and they attend sessions or they participate for 6 to 12, whatever it might be, they realize it's really not for them. They're not that interested. They want to disengage. And you need to have a respectful way for them to tell you that, and a good way of letting them exit and recognizing the contribution that they have to give. Secondly, given that you're dealing with patients and caregivers, as you all know, crap happens and their circumstances change and they just simply can't do it anymore. So again, you really want to be able to allow them to come to you and say, I really want to stay engaged, but I can't. And be prepared to then fill in and back to recruitment. You don't want to have your 32 going down to 17 and have no way of replacing people. So you need to think about what you're going to do when people drop off, because they will. And then something that we didn't really anticipate is that sometimes they don't want to stop. And so, we had 3 years of engagement, and there were some very emotional moments at our last meeting. We hadn't prepared for that. So you need to be clear with people at the beginning what the time frame is, and you need to have a very respectful exit strategy. You have to prep them, particularly if you are in an environment where they are engaging with, say, very high-powered clinicians. There's a lot of jargon, or senior government members where there's all these acronyms and nobody knows what on earth anybody's talking about. So you do need to plan for, a bit of an orientation and try to assess what they need to know. Don't make assumptions, but ask them. So we did a little survey and we gave all kinds of options. And when we started with the Panorama panel, they said the first thing they wanted was a healthcare 101, a primer. What does the CCC do again? And what's the LIN's role? And how does the funding work? And that kind of stuff they felt they needed before they could engage on any kind of system reform conversation. The second thing, if your engagement exercise is very predicated on experience and people telling their own stories, you need to help them learn how to do that in a way that isn't overly negative. But of course, the stories usually or often are predicated on something that didn't go very well. But you need to help people be able to extract the lessons and what would be better next time around, so that it doesn't become, a very complaints-driven conversation. So you really need to spend some time thinking about, how to prep them before you begin the actual engagement. What do they want? What do they need? And give them a sense of, confidence that when they're at the table, their contributions are going to be respected. And sometimes that also does mean, depending again on where you're doing this and how much involvement you're going to have with frontline staff or clinicians, you might actually need to do a bit of a session with them as well to talk about respecting the story and not necessarily taking things personally. Yep, expect the unexpected. Stuff goes off the rails, and you need to not feel that that's a negative thing. As the groups, particularly if you are bringing together people face to face, they often form friendships and they become close, and then they start talking about things they'd like to do that you haven't got on the agenda. So you need to be very open to things being suggested. And you then can bring it back to remember what we said we could and couldn't do. So if it fits, and the sort of dialogue rules. So don't rule it out. And, I would say plan for a couple of things that are going to get done that you just simply had not anticipated, but it makes a ton of sense when, you see how the evolution of the dialogues occur. So don't see this as a negative. Embrace it as a positive, because people want to do more, or they want to encourage you to think about something you hadn't thought about. You do need to recognize, and this can be in many, many formats, you need to obviously acknowledge contributions and impact anytime you're talking about the work, presenting the work, whether it's in writing or verbally or in presentations. You need to recognize what they've done and how they have helped you in that regard. You need to go back to them, even if, and this is something we didn't quite pick up the first time through, because we felt like if we went back and said, oh, we didn't do what you said, or we couldn't do what you said, then that would be discouraging to them. But in conversation, we started to realize not necessarily. They want to know that the work has been heard, embraced, and that you've attempted something. And even when we went back and said, here's what we did, and here's why it isn't proceeding, people were, they weren't always happy, but they certainly respected the fact that we looped back, and that, we've all experienced it when we've been to meetings and lots of great stuff is discussed, and then you never know what's happened to it. It's gone off into the ether somewhere. So go back when it's positive, but also go back when it isn't so positive, because they need to know why. And again, it's back to the what you can and cannot do. Sometimes, trying to proceed with something was beyond scope and it just wasn't going to land. But respect them enough to tell them why. Again, this was something that we had not necessarily anticipated, but in reflecting later on, we realized this is pretty normal. At the beginning of a lot of engagement exercises, there's a ton of enthusiasm. It can be quite intense because you're often, meeting a lot. You may be doing training. You may be sending people away together for, a workshop or a conference. And there's a lot of intense activity. And then as you get into more of an implementation phase, so the design work has been done, and now you're into sort of embedding practices in the organization, you may not have as much intensity or as many exercises with participants, and some of them can feel like things are drifting. And so it's good to kind of flag this at the beginning if you have a sense of when that might occur, to talk about it and sort of normalize it in some ways, that it's not that you don't care about them anymore, but here's what's going on. Or think about other things that you can move them into as you are implementing the work that you've done through a co-design set of activities. Again, this was something we probably didn't think enough about. Particularly, again, if you are asking people to tell stories, it can be very emotional for everybody. And even stories that are not, particularly current. So things come back to people as they vocalize what happened. And I'll just give you a quick example because it sort of underlined it for me very recently. I do a lot of presentations, and we try very often to have a patient or a family caregiver on the stage at the same time. And we often start with that individual's story. And there's a woman that I've worked with a lot in Hamilton. Was very articulate and very comfortable speaking, and very good at extracting the positives and the negatives from her own experience and caring for her husband who passed away 5 years ago. And we were recently getting ready to get up on stage, and she just looked at me and she said, "I cannot do this today. I'm not doing it." And fine. So I got up and I explained, this is why. And so keeping that in mind, that the expectations that people can just go back to that situation that brought them probably into an engagement environment in the first place, it's not automatic. So you do need to think about that. And you need to, if you're doing, in our case, we were bringing people into Toronto for a weekend 4 times a year. So it was quite intense. And we ended up realizing that we actually needed to have a bit of support available for participants if they were experiencing upset. But again, something I didn't anticipate but realized later, also for the staff. We had a series of engagement exercises with children with cancer. And the same woman was doing most of the facilitation for that. And she called me after probably half a dozen and said, I need a break from this. So you really have to think carefully about the emotional aspects for everybody involved, and have something available if required. And then the last lesson, think about a bridge. In our case, we'd invested quite deeply over a long period of time with our 32 individuals, and also the PATH participants who've been engaged over a couple of years in all kinds of engagement exercises. So now there's this cadre of people who are very well informed, very comfortable in an engagement environment, understand the philosophy and practice of experience-based co-design, and want to continue to contribute. So we felt that we had an obligation to kind of think through where else could we connect people, whether it was locally in their own community or elsewhere. And we were able, for a number of people, to get them involved with LIN or CCAC councils. A number of them got involved with HQO. A couple of them, I think, are on the HQO Advisory Council or acting as improvement advisors. So if you can, I think it's really worthwhile. I guess it's a public service, if you like, but it makes some sense to just not say, okay, bye, and leave them to their own devices to figure out where else they could participate. So just a couple of reflections beyond the formal 15 points. This is coming out more and more, and so I thought I would spend a minute on it. Obviously, you must pay for expenses. And I know it's tricky as a publicly funded organization because you have guidelines that you have to abide by. We were lucky, because we are not publicly funded, that we had a little bit more flexibility on that. But I think it's worth thinking about because you want to make sure that you're doing everything you can to enable participation. So if somebody's a caregiver and they're leaving a family member or friend at home while they come to participate in your exercises, you may need to pay for some attendant services while that caregiver is not providing that role. You may need to provide for attendant care for somebody to come to participate in person. So for example, in our case, again, we had people coming into a hotel for a weekend. We had a couple of people who needed PSWs, and CCAC wasn't going to pay for that, obviously. So we had to support that. You have to think about childcare. In a couple of cases, we paid for dog sitting overnight because somebody was coming from up north, obviously wasn't going to bring the dog, and if the dog wasn't looked after, they were not participating. And you have to think, obviously, about accessible transportation if you're moving people around physically from location to location. So it's beyond parking, and it's beyond meals, and it's beyond mileage. Compensation. We are getting a ton of questions on this. Practices really vary. We have to say that nobody in our projects actually raised it as a demand. We were at a conference in the UK where it was a major source of tension, and it made us think, okay, we probably need to deal with this before it actually is in our face. So we looked around, we did a bunch of background research, tried to figure out what other people were doing, and it was all over the map. So we created a little framework. It's a decision process. It doesn't say you should or shouldn't, but it actually helps you decide in what circumstances would payment be appropriate. The framework is on our website. There's a little decision tree that you can simply print off and work through. I think it's important whether, even if you end up deciding you're not going to do it, I think it probably is of value at least to be able to demonstrate that you did give it consideration and the reasons why you've made the decision that you've made. It's a matrix. It's based largely on the time commitment and the intensity of the contact that's required. And it really does come up when you are in situations in which there are paid staff at the table contributing in a similar way to the patients and caregivers, and they are paid, obviously, so sometimes the question comes up. When we moved into paying, interestingly, in a couple of our exercises, a number of the PATH group actually donated it back. And a number of the Panorama people either declined or asked us to contribute to charity. So you may find that it's not actually something that people really want the money, but it's a recognition that, you know, their value is equal to the people who are being paid. In some cases, people take the money, which is perfectly fine. So I'm going to stop there. Ken is going to moderate for me in terms of whether we have some questions, and we'll see how that goes.
Yeah, so I just, as on the slide, I just wanted to point out the link is there for the complete report of the Panorama Rules of Engagement project and more detail on their resources. We do have a question from participant SMH, and I'm going to give myself two guesses. Would that be St. Mike's Hospital or perhaps Stevenson Memorial? But Kathy, you mentioned providing support to patients while they're sharing their stories. And this audience member is wondering if you could share some examples of that.
So, you know, when we started, we, let me say, assumed that if we said to a couple of people, let's start the meeting with your stories, that they actually, you know, kind of would have organized their thoughts, and it often ended, I'm sure you've all experienced this, it ended up being a fairly chronological, and then this happened, and then this happened, and then this happened. And so you're listening to the story, but you're trying to get to how do we extract. So we did a couple of things. We went to, we started with rehearsing. So if we were going to ask people to tell a story, we would sit down with them in advance of the actual engagement exercise and just let them tell it, so that we could hear what was important to them and, you know, where they were emphasizing good or bad. And then we would turn it into a set of questions that they could answer. So it became less of somebody telling their story and more of a little bit of a structured, almost like an interview, which actually, we didn't do the interview in front of people, but it enabled them to organize their thoughts so they could start off with, you know, here's the basic situation, here's what I didn't like about it, here's what I loved about it, here's what have made it, you know, would have made a difference, instead of the kind of chronology of events. And then that was much simpler for the facilitator and the other participants to then engage in an improvement conversation, instead of everybody just going, oh boy, that really was, you know, that didn't go well. There are also a number of resources from the Institute for Patient and Family-Centered Care, which some of you may have looked at online and or maybe even attended some of their training sessions, where they have a number of templates that help you think through. So it really is the advanced prep on why are you telling the story? So there needs to be a purpose, right? You don't just want stories because and I worry about this. I think it's becoming a bit of a tick box. You know, we have to start a meeting with a story and then we get on with the meeting. You need to tell the story because you want it to contribute to the conversation in the meeting, but you need to have it organized in such a way that you're extracting the improvement lessons from it. Because if it's just somebody who really wants to impress upon you how nasty the situation was, then that probably needs to be in a patient relations or some other forum where you can actually tackle that individual set of circumstances.
And I will work to get the
Sure.
links, acquire the links to those resources from the Institute of Patient-Centered Care, and forward them to you all. There was a question earlier on whether this session you'll receive the slides and can view it later. We are recording it, and I will be sending out an evaluation either today or tomorrow for you to complete, and you'll get access to the recording and the slides. In the meantime, our friends from RGP Central, Jane and Anisha, have a question about recruiting patient advisors. Did you have names put forward, or how did you get the names for those initial stages?
So I'm speaking specifically now to the Panorama, which was our advisory group. I'm not speaking specifically to PATH, because PATH had a local and different process. No, we did not do that. We did not have names put forward. We wanted to really go completely neutral. So we, as I said earlier, we hired a polling firm simply because they have the phone infrastructure to get to people. We created a set of criteria for what we were looking for that did have geographic, ethnic, income, I forget what else, education, a bunch of different criteria. And it was hard for them, I have to say, to get 32 people. It probably took them 6 weeks of pretty intense work to get to where we wanted to be. And then when we looked at our list, and we looked at the profiles, and we literally knew nobody. There was not a single person on that piece of paper that we had any contact with whatsoever. We still realized that we were short, particularly around the ethnic diversity, the disabled community and Indigenous. So then we went to community organizations and said, could you help us? We need one person or two, whatever it was, because we really wanted to round out what we had, but we didn't start there. That is another way of doing it, obviously, because if you don't have the ability to do that cold call process, you've got to get to people some way, and there's nothing wrong with going to leaders, community leaders. You just need to think about, what are you getting? Just think through. So you're still probably getting slightly more connected folks, but maybe not. So, another way of doing it is actually to not ask them for names, but to ask if they would advertise on your behalf. So it's a matter of just kind of thinking through what you need to do, and being clear on what you want as an end result, and then patching in what you need to patch in if your first set of exercises doesn't get you where you really want to be.
Great. And just a quick question from Amanda about the slides being available on the RGP website. Yes, they will, Amanda. I will send them through a SurveyMonkey link through the evaluation. But if you have trouble accessing that, I know some organizations have SurveyMonkey blocked. My email address will appear on the next slide, and you can email me, and I will link you to the resources. This and previous webinars are all archived. But moving along, we have Sean from Bridgepoint, also who goes by the alias of Jason, who has a question about the 15 lessons regarding conflict management in those group interactions. Wondering if you could describe some of that and some helpful advice around that.
Yeah, that's a great question, Sean, Jason. Yes, so obviously there's conflict. So I'll deal with the two things separately. And it goes back to, first of all, you do need a skilled facilitator. This is not something you can do if you do not have facilitation experience and skills. And we set a tone at the very beginning that we actually encouraged differing views, so that we didn't try to push people into resolving a conflict. we simply said, okay, there's a couple of, and we're going to document all of this. There's a view of X, there's a view of Y, there's a view of Z. So we would absolutely catalog that in a very neutral way. And then often what we would do is, rather than try to kind of get to a consensus in person, we would then do an online exercise. We would ask people to comment. Sometimes we ended up asking people to rank order the different priorities. It was usually around priorities where we had a conflict. And so people were able to not have to, kind of, I guess I would say, argue in front of each other, but they were able to express online. And then sometimes, and this is where you go back to tell them what you did with the advice, we would go back and we would say we actually couldn't find a consensus on this one. So either we're going to just leave it for now, and we were able to do that given the nature of the work that we were doing, or we say, here's what we think the solution, or here's what we think the accommodation is. Are people comfortable with it? And then we would allow them. We had clickers in the room for voting that were anonymous. So we would then test, and we would allow that up on screen. So nobody knew how anybody was voting. And we would get a very quick, okay, we're still all over the map on this. We got to go back to the drawing board, or people are satisfied with the resolution. In terms of group decision making, we actually were not really asking them to make decisions. And again, this is the nature of the foundation, right? We're not providing services. We're not dealing with direct patient care. We don't have to necessarily get super specific. So let me give you the example of the navigator, because that was a real, that people had very strong views on, do we need a navigator or not? I mean, it was either a yes or a no. And so rather than making a decision, we said to them, you know what? We're not going to come to a conclusion here. We are going to outline the viewpoints, and that's going to be the product. So, we were constantly assessing whether pushing them into, or not pushing, facilitating them into a decision was going to be a bad idea or a good idea. Now, I appreciate, given delivery organizations, that may not be so simple. But I would, if you can afford it, the idea of the anonymous voting in the room is actually really helpful, because people don't necessarily want to put their cards on the table, and they don't have to declare in person by using the technology, and it's not particularly expensive. And people can see right away, like the results go up. It's not like the Change Foundation went away, came back later. They go up on the screen as people are voting, and then there's an interesting discussion about the results. So I hope that's helpful.
Great. So in our last few minutes, I would like to invite the audience, to invite you to share, perhaps those of you who have had patients and community members involved in your projects, maybe share some of your nuggets of success, maybe some of your challenges that perhaps Kathy can reflect on. And while you're thinking of some of those things to share, I might ask, I have a two-part question. One is, when I look through these 15 rules of engagement, I think as well they may read very similarly there are times when we are asked to be expert panel members for other organizations' committees, and we ask other colleagues to participate on committees for work that we're doing. A lot of them read very similarly, but what key differences would you want to highlight for engaging patients and community members? So that's part one of my question. Part two is, you mentioned your cadre of 32 more experienced patient participants. Were there learning nuggets for them that they reflected on that helped them to become more able contributors? Yeah. So those are my two questions.
Okay, so the first one was the sort of nuances with patients and caregivers. And I think it really is, just don't make any assumptions, about what they know or what they don't know. Think back. We got this whole great agenda orientation session and blah, 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 blah. And then it occurred to us about, I don't know, maybe 3 weeks before the group was coming into town, that maybe we should run it by them. So we sent it out. The whole thing got thrown out the window. So I think, whereas when you're in an environment where perhaps it is colleagues and you have a bit of a, you have a more familiarity with what their role is, what the organization is, what they know, what they don't know. So just, don't assume. And then the second part was, remind
Was
me? What did they
learning?
learn?
Yes.
Interesting. So I think when we did our final evaluation with the group, and I think this would be the same for both the Path and the Panorama. The thing they really got, the first thing they said was they learned so much about how the healthcare system worked that they didn't understand before, and that was for them a huge plus. But they also felt confident. So when they were asked to do things, and in particular, we had a couple of people who went to HQO who advised on setting up their engagement frame, because if you recall, that wasn't in place until a couple of years ago, and then a number who ended up on both the Technology Assessment Council and on their Patient Engagement Council. They spoke about how comfortable and confident they felt going into that environment because of the experience they'd had, with the Panorama. So don't underestimate that part of it as well.
Yeah, so Jane and Anisha from the RGP Central, they support coaching, working with the patients and families about their lived experience, but learned they had a difficult experience in that people identified in the dialogue, people were being identified and
yes.
named, even though they had been cautioned about privacy. So they're very aware of the emotions that can come from that.
Yeah, I would just underscore the importance of that. And that is that is a very easy thing to do when you're doing the prep work, is to make sure that names both of family or patients and also of staff stay out of the conversation. And that, when you're in that kind of here's what happened, that's often when privacy gets breached because people forget and they name. But when you're in the question, it doesn't come up as much. So that's a great point, and it's definitely something that has to be repeated over and over and over again.
Yeah, and Joanne from Cornwall, Joanne's a colleague of ours from our Senior Friendly Hospital Collaborative, and in their Senior Friendly project, getting patient feedback and listening to the experience of patients, particularly to their experience of hospitalization, was crucial. Their takeaway was to listen to the patient's story.
Yeah, and I think it's a real trick, and it's the how you listen, right? So it's not so much the little tiny details. It's what do we take from this that was the process we imposed, and do we have the ability to change that process? And so it's the filtering on the story to be continually looking for the improvement opportunity, and it's a different listening skill that I think than just, and I don't know, that's not the right word. It's a different listening skill than being empathetic, which you also need to do. But you have to have the radar up about the improvement opportunities.
Yeah. So we have about 5 minutes left. There's a couple more comments being typed in, but please feel free to, in these last few minutes, to share your experience as well. I think we often in these webinars learn just as much from the audience as we do from our invited speakers. I might provide a little shout out to a team I've been working with in our senior friendly hospital work. They may be on the line, and I apologize if I embarrass you, but from Huron-Perth Health Alliance, they had a patient partner as part of their team as well, working on their project. And this patient partner was involved directly in the education of frontline staff, and also wrote the article in their hospital newsletter about the project and her experience in. And I can say that from both ends, from the team that recruited her and from their patient volunteer, it was a very happy experience for both. And Anne has just validated that here on Perth. So a shout out to that team. They've actually presented a short webinar on that experience, and it was a very positive one for both parties.
And I'll just chime in here because I get to promote this. We've just announced for Changing Care Projects, which is a 3-year commitment from the foundation to work with teams who are really interested in changing the family caregiver experience. And Anne is the sponsor for the Huron-Perth group. So glad you're on the line, Anne.
Yeah, wonderful. More comment from Jennifer. To your point in number 10, rule number 10, humility is key. And that's a big lesson learned through PATH.
Yeah, and Jennifer was very, very instrumental to the PATH project. Hi, Jennifer. Yeah, you really have to just park it at the door. I mean, we actually almost had a lesson, and then I think my team thought this was going over the top, but leave your ego at the door. Just, listen, be empathetic, and be very respectful of what people are telling you. Because often they're very vulnerable in those early situations, and they need to feel supported, and they need to see that them sharing what they've shared is actually having an impact on the organizational work.
So this has been all great discussion, and I think just reflecting on what you mentioned at the start, Kathy, these are all very common sense rules, but I think packaging it in this resource is very helpful to keep us mindful, because as we're now embarking more and more in integrating patients and families, community members into our work, I think sometimes it goes really well and sometimes it goes not so well, and taking a moment to reflect and to ensure that we observe some of these commandments is very helpful to guide us as we continue to learn and grow our success in this. So I think we welcome further questions, but as we come to the end of the hour, I'll give you a few updates, is that I will send you a quick evaluation survey, and this survey will link you to the slides and a recording of this webinar you can view later. Save this date. We have another webinar planned for you, Wednesday, February 22nd. I'll soon be sending out notices for that as well, but we will have Hospice Palliative Care Ontario joining us and talking about healthcare consent and advanced care planning in Ontario. They're going to have a leaning towards the hospital sector in this, and they're specific to Ontario legislation. So I think this will be an important one to attend, so please mark your dates. There's my email address if you have any further questions about the webinar series itself or about this. If you want to connect with Kathy and her team to discuss the resources more, I can facilitate that.